Next up, I believe we have Bob Haras, who is the Director of Program Development at Harm Reduction Services in Sacramento. Bob received her Master's of Social Work from California State University in Sacramento and has worked in the field of social work for the past 17 years. And she's going to be sharing a little bit with you about harm reduction services and opioid use and youth data. So Bob, please take it away.
Oh, hello. Hi. Sorry, I didn't unmute myself. Thank you guys for having me here. So today I appreciate you guys having me come talk about harm reduction in youth. I'm going to talk a little bit about what we do, what harm reduction is, some of the data that we have from 2021 for youth, and then talk about some of the barriers to harm reduction programming for youth and how we can kind of try to make that system a little bit better, if that makes sense. So let's see here, let me get this going. There we go. So just so you're aware of what our agency does, we're one of 4 agencies in Sacramento that are doing syringe service program. And with that comes injection counseling, particularly for young people, because they tend to learn how to do things off the internet nowadays rather than, from somebody who knows what they're doing. We also provide safer smoking and snorting kits that have like educational pieces with those to get people thinking about how they can reduce their risk. We also do HIV, Hep C, chlamydia, and gonorrhea testing with a risk reduction counseling session. And we also do weekly STI testing and safer sex education at Luther Burbank High School. They're the only high school that's kind of invited us to come and do harm reduction in regards to sexual health. We also do Ryan White medical case management for HIV positive people. We have a support group for HIV positive participants. We also have our education response and access program, which is our drug treatment navigation. And I think Rachel, one of our case managers, is actually on this call right now. And then we also provide safer sex supplies and survival supplies like wound care, hygiene kits, over-the-counter cold and flu medication, which has been really important the past couple of years, and anything we can get our hands on that we can give out to people for free. We also do overdose prevention and response training, and with that comes naloxone distribution. And in 2021, we did distribute over 22,000 doses of naloxone, and our program participants have thus far reported for 2021 that they saved almost 2,000 people. So that was pretty awesome. And then we also partner with UC Davis School of Medicine for the Joan Vitera Memorial Clinic, which is like a 2-prong program where we're teaching incoming medical providers how to work with drug using populations, but then also we're creating an environment where there's a positive interaction for people who use drugs who are seeking medical attention, who may have experienced stigma from like a primary care provider or something like that. And then anything we do in the office, we do out in the field, which includes our street outreach team, which is out in the field doing all this work 5 days a week. And then we also do a once a month street medicine program with UC Davis School of Medicine, where we take our students out. And we also do community cleanups. So that's kind of fun. So just so you know what we do. Okay, so I just wanted to go over basically what harm reduction is in a nutshell. So harm reduction is defined as a set of practical and realistic strategies and ideas aimed at reducing the negative consequences associated with drug use and other risk behavior. I like to call it compassionate practicality. And the idea is to meet people where they are, like emotionally and also physically. So some of the principles of harm reduction is a movement for social and health justice built on the belief in and the respect for the rights of people who use drugs. Does not attempt to minimize or ignore the real and tragic harm that can be associated with drug use. Drug use behaviors are on a continuum of severe use to total abstinence, and that some ways of using drugs are clearly less risky than others. And so I think sometimes people think harm reductionists are against abstinence, but what we're against is abstinence only, because we recognize that people are going to use drugs. And so we want to make sure that we're reducing any risks that they might have associated with that drug use. Some of the principles are non-judgmental, non-coercive provision of services, and quality of the individual and the community life and well-being, not necessarily the cessation of all drug use, is as the criteria for successful interventions and policies, which is a little bit different than I think some people might agree with. People who use drugs might have, must have a voice in the creation of the programs and policies that affect them. One of the rallying cries is nothing about us without us. So they have to be involved in every aspect of programming and policy because it affects them. Affirms that people who use drugs are the primary agents of reducing the harm of their drug use. Therefore, they should be encouraged to share information and to support one another because they're going to know better than anybody else, like what's working for them, what's not. And then recognizes that social inequalities affect a person's vulnerability to and capacity for effectively dealing with drug-related harms. And a lot of, like I've said before, one of the biggest things that we hear about harm reduction is that we are enabling people to use drugs, but that's obviously not true. We're just helping people improve their health wherever they are in their drug use, if that makes sense. So the CDC has actually done lots of studies on harm reduction programs now, and so we understand the efficacy of harm reduction. People who go to a harm reduction program are actually 5 times more likely to enter drug treatment than people who don't. They also reduce overdose deaths, obviously, because we're handing out naloxone and helping people strategize about how they can not overdose. And then it also prevents HIV and Hep C transmission in ER visits. The CDC also found that it supports public safety because it reduces syringe waste, which seems, some people think is counterintuitive, but they compared cities, of comparable size and everything like that. And then cities that had syringe service programs had less syringe waste than cities that did not. And there is no increase in crime that they found if there's a syringe service program in a city. And people who go to a harm reduction program are more likely to reduce how much they're using or stop injecting drugs and go to smoking or snorting than people who don't. And then it's also cost effective because every dollar spent on somebody who goes to a syringe service program or a harm reduction program saves a taxpayer like over $7, which is, if you care about that sort of thing. And then just so you can look at some of the data that we've got. So these are folks who came and got services at our syringe service program. Not all of people that come to our syringe service program are injection drug users. Sometimes people do come for our safer smoking and snorting kits as well. So in 2021, we served about 952 people who were under 30, which is about 18% of our program participant population. And I would like to, yes, the gender and ethnicity, we can see all of that reflected also in the previous presentations as far as representation. But then doing this for 10 years at HRS is how long I've been with HRS. The drug of choice kind of has changed a little bit for our participants. It used to be very distinctively like people who use opiates, people who use stimulants, so they actually used to kind of talk crap about each other. And now we're seeing a lot more polysubstance use. So a lot more people using both opiates and stimulants. And then, so this is not our data. This comes from the CDC. It's the California High School Risk Behavior Survey from 2019. And I like to throw this out there because I think sometimes, we think of drug use and injection drug use as kind of like an older person's problem. But as you can see from the survey, they found that quite a few high school students do take prescription medications without a prescription or differently than how their doctor prescribed. And there is some experimentation with injection drug use, during high school in California. And so I think that reality is kind of what I'm trying to put, show the face of, because we can say abstinence, 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 but it's really, really important that we recognize that teenagers are using drugs and they need to be able to reduce their risk in doing that. And so that's something that harm reduction tries to achieve. This is some of our data that we've got. This is all of our participants, not just our under 30 participants, but I think it's an important set of data to kind of show people. Now, these are people who did end up injecting drugs. And so it's a little bit riskier type of drug use than like smoking or snorting or ingesting drugs. But they all didn't start that way, is kind of my point. So basically what we're looking at, we asked our participants 3 questions, like, when did you first start using opiates? When did you first use heroin? And when did you first inject drugs? And so for our population, you can see, I was actually surprised by this data. I thought it would be much later that people started experimenting with opiates. But as you can see with our population, it was very young, like 12, 13, 14, 15 years old. And you'll notice there is a correlation between heroin use and injection drug use because heroin is best injected. And then also you'll see that there's a larger spike of injection drug use the older that they get. And then part of that is because, you know, they might be leaving home, they may not have access to health insurance, and, you know, street drugs are cheaper, you know, than having to get them from a doctor. And so that's kind of why, and street drugs are best injected, if that makes sense. It's more cost effective, if that makes sense. And then they kind of talked about this, but this is also from this CDPH. I'm sure you guys have seen these charts, like a previous presenter kind of pointed this out, but this is the opioid related deaths in Sacramento. This is from 2020, and I think he had 2021 data, so that's awesome. But the point is that young people are using drugs, and they're at a higher risk for like HIV infection, overdose death, and like soft tissue infections if they don't know what they're doing. And so basically the argument that we're trying to make is that, yes, we need to have like drug treatment programs for young people, but we also need to be realistic about how we can, I always like to say, you know, keep them alive so that they could make choices about drug use later on. And there is what I'm going to talk about next is basically from the Harm Reduction Journal up in Canada. It's an article called Developing Harm Reduction in the Context of Youth Substance Use. And they basically talk about some of the barriers to developing harm reduction programming for youth specifically, and then what youth say that they would like to see in harm reduction programming that they think would actually, that they believe would help them. And good. So basically, one of the barriers to having a youth-focused harm reduction programming is legality and a lack of knowing their rights. And so that's one of the things that, like a lot of young people, there are legal issues around, you know, providing drug paraphernalia to a young person, even, you know, even if it may be less risky drug paraphernalia than, like, say, a syringe, but, you know, we're not necessarily allowed to hand like a 14-year-old a pipe, if that makes sense, even though it's less risky than injecting drugs. But then also a lot of students don't know what their rights are. And so when we are working with young people, especially at the high school that we work with, we're not really allowed to kind of talk about their drug use. That's not really what our function is there. Our function is to talk about their sexual health. And even then, they don't know what their sexual health rights are. And in California, there's a lot of rights for young people around their sexual health, in the sense that you can access sexual health from the age of 12 on. But so there is an understanding, I think, in California of harm reduction around sexual health, but there's not so much an understanding about harm reduction around drug use. And there's also, that's basically the lack of political will to change the current curriculum around drug use. So it is very abstinence only focused. And abstinence is part of everything, but then sometimes that can not be relatable to a lot of young people because of whether they're using it for coping mechanisms or if they're just experimenting. And then there's also a fear of law enforcement and other authority figures as far as like whether or not they can access services for harm reduction. And then obviously parental rights over children. So parents, you know, they love their children, they want to do the best for their children, but like I was saying with the understanding of harm reduction around sexual health in California, there are some parents who don't agree with that either, you know what I mean? But the reality is, you know, children are using drugs and parents may not like that, but that's the reality, if that makes sense. But it will prevent their children from accessing harm reduction. And then the presence of older people at SSPs, because most syringe service programs are for 18 and older. They're not, you know, because of legal reasons, you know, we can't serve people who are under 18. And so they don't necessarily, even 18-year-olds and 19-year-olds are a little hesitant, you know, this study found, to access syringe service programs because of the presence of these older people, and it makes them uncomfortable. And so it makes it a barrier. And then distance from program, that was one of the other findings that they had, was that like younger people are less likely to have a car or have transportation or feel comfortable using transportation to get, you know, public transportation to get to harm reduction programs. And then paraphernalia laws, like I was saying before, you know, right now in the state of California, it's not, you're allowed to have possession of syringes, but you can't have possession of a pipe, which is a less risky type of drug use, or a snorting kit. Like those, you know, especially for young people, they're not allowed to have those things. And so it kind of is like a little bit lopsided as far as the paraphernalia laws. So some ideas for creating harm reduction programming for youth. What the study found was that education about harm reduction and efficacy, we need to do education about harm reduction and its efficacy to parents and community members to kind of create that political will and understanding of like why it works and why it needs to be, in addition to treatment programs, there needs to be other programs that are being honest and talking about, you know, how to reduce risk around drug use. And then also they found that it needs to be peer-led programming. Youth are more likely to listen to other young people. They don't want to listen to me. I'm 40 years old. They don't care what I say, you know. And then they also said that avoiding using authority figures in the youth programming was helpful for youth who are using drugs to feel comfortable talking about their drug use openly, which is incredibly important when it comes to harm reduction. And then establishing programs in venues and locations that youth can easily access safely. Some of the suggestions from the study are like pharmacies, primary care clinics, schools, music venues, and festivals, because these are where young people are. And so rather than expecting them, because one of the principles of harm reduction is meeting people where they are. And so, you know, expecting youth to come to a harm reduction program doesn't really make sense because they're not comfortable coming to a harm reduction program. So to bring harm reduction to where they are, whether it's in a pharmacy or primary care or school, or like having a booth at a festival or something like that, would be more effective for them in reaching youth. And then housing first, like that's always a big one, is that, you know, making sure that especially unhoused youth, which is a huge problem, making sure that they're able to get housing before we worry about all the other things. Because when we're talking about Maslow's hierarchy of needs, people can't even start to work on their mental health issues or anything like that unless their, you know, physiological and safety needs are met first. And so that's huge. Expecting young people to work on their drug use while they're living on the street doesn't really make sense. And then incorporating harm reduction into health curriculum about drug use, sexual health, and general health, because harm reduction can be used for any risk reduction. And I think to make it like age appropriate, you know, when we can start as young as, you know, elementary school, just talking about seatbelts and sunscreen and like, you know, using those words around harm reduction and getting, because harm reduction is about loving oneself and it's also about critical thinking, because we have to, as a young person, they're going to do risky behavior, but they can also develop critical thinking skills as they grow. And that's part of harm reduction. And incorporating it into health curriculum can help with that, to kind of guide that, if that makes sense. Oops, sorry. And then using social media that's relevant to youth. Right now it's TikTok and Instagram. Facebook is out for young people, I'm told by my Gen Z employees. This will change over time. And that is, again, why it is so important to involve youth in developing programs that are relevant to them in that moment, if that makes sense. So, you know, social media is going to change, but that's why it's important to involve young people in the programming. And you can kind of see that. So we have one of our young employees who just started our TikTok last year, and already it's so popular. We have over 135,000 followers in our TikTok. So it's really helping to kind of get the message of harm reduction out there. And it's been really surprising how well received it is. And so this is my contact information. Add us on TikTok. It's literally just at Harm Reduction Services. We're also on Instagram. And so, you know, kind of check out the kind of stuff that we're talking about on there and all that jazz. So thank you.
Great. Thank you, Bob. Looks like we have just a couple of questions in the chat. Again, feel free to raise your hand if you have a question. I'll call on you in just a moment. So the first question is from Yesenia. Is the program open to those who are homeless?
Our program at Harm, yes. Our program is open to anybody 18 and over.
Okay. And then another question from Caitlin is, what is included in the safer smoking and snorting kits?
Sure. So basically what we include is instructions so that people understand kind of what is involved in all of the items that are in the kits. There's different kinds of kits because people smoke in different ways. So there's foil kits, and then there's meth pipe kits, and then, you know, crack pipe kits. And so those are going to have different things in them, if that makes sense. But we have things like what we call a pipe condom or a pipe tip, so that like when you're sharing a pipe with somebody, sometimes the pipe gets really hot and you might burn your lips. And so you have a pipe condom, which is made of rubber, so that you can take it off, you're not burning your lips, and then you can pass the pipe to somebody, you're not spreading blood to each other. So things like that. Does that make sense? And then like the smoking or the snorting kit will have like a dedicated surface to snort your drugs off of, rather than going to the club and snorting off the back of a toilet or a counter or things like that. And then there's also things included like different colored straws, so that when you're snorting with your friends, everybody had like, I'm blue, you're red, this one's green. Sense. So the idea is not just to provide the equipment to people, but it's to get people thinking about how they can care about themselves and reduce their risk when using drugs, especially with other people. So there's a lot more things in the kits, but that's just an example. You can come by and check one out. Stuff on fire.
Great. Thanks. And then it looks like Lori, your hand is up. Please go ahead.
Yeah, I want to say thank you, Bob. It was nice meeting you virtually. I know we talked on the phone and I had some email exchanges together, but a couple of questions from the county level. You spoke about the drug trends in terms of seeing polysubstance use, your opioids, and your stimulants. And in terms of the stimulants, are you seeing methamphetamine? I heard cocaine's coming back a little bit. I'm hearing through the grapevine, so I wanted to hear a little bit more about that through our partners that offer data to us, just so to make sure that, you know, we're kind of aligned with what's out there.
Yeah. And I think Sane's on here. I think Franz is on here too. And he might also have a lot of information. Sane is another one of the SSPs in town. So just FYI, he's a good person to, you know, tap into his brain. But yes, we're seeing methamphetamine, cocaine. Yeah, absolutely. Methamphetamine particularly. Okay.
And then you mentioned some of your services are community cleanup. So we get a lot of calls at the county, you know, needles everywhere, a lot of concern from neighborhood associations and partnerships about, you know, working together to get neighborhoods cleaned up. So if somebody does call us, are you or other harm reduction organizations able to go out and get that stuff cleaned up, or is there another process for that?
So we do, if somebody calls us and tells us that there are syringes in their area, we will go out there and pick them up and then do outreach and hand out, you know, sharps containers and such. But I do believe the city has a service for biohazard cleanup. And I can't remember, I think it's called, oh, Rachel, do you remember what it's called? Sorry, Franz, do you know what it's called? The city does, they actually hire somebody to go out and pick up. We will do it if you call us, but just be aware that we are a agency of 12. So we do not have a large capacity to do huge cleanups, but the city did hire somebody, an agency to do that.
Okay, I'll look into that. I was just curious. And then last question, when young people are coming into your organization, how much counseling do you provide? Are you encouraging counseling and enter into treatment services? I know your harm reduction and all your services are great in that respect, but I'm curious about the percentage of referrals to county treatment programs and how much conversation is happening in those areas. And then just to make your staff aware, and you can maybe connect with Tricia at a later time, we provide substance use disorder assessments by phone now. So if you have a young person that you're seeing that maybe will be open to treatment, you can get them connected that moment that you're in a conversation with them. So I think it's really helpful right now and a benefit, having this telemedicine, telehealth option for young people. So I'm just curious of what percentage are you seeing are young people open to it?
So the way that we work all of our programming is that when somebody comes in to our agency, sorry, I'm taking up a lot of time, so I feel really bad. But when somebody comes in, especially if they're new, they may not feel comfortable talking about their drug use. I think sometimes when people come in, they're very shocked by how open we're being with other participants who've been coming to us for a while. Like people come in and use euphemisms for like pipe stuff, like, you know what I mean? And we're just like, oh, you mean like methamphetamines? And so that's kind of uncomfortable for some people, but over time, we basically have to gain trust and like that they feel comfortable opening up to us about their drug use. Rachel, who's on the call right now, is our drug treatment navigator. We basically, her advertisement is there. Everybody who joins the program is told of all of the services that are available, but we do not push treatment on people. But she is busy all day long. And so it's not an issue. Like, people who are ready to talk about treatment, they know that they can talk about treatment with us. But they know that we're not going to push them into anything that they don't want to do. So when people do ask for Rachel's services, like, they're ready to go, and then she takes care of them. And she does navigate people into the county sometimes as well. But we do work with other partner clinics, buprenorphine clinics, like SANE. So I hope that answers the question. Yeah.
Yeah. And then last question for Lauren and Lindsay. TikTok, Instagram, Snapchat, that seems to be kind of the direction. So I know we're focusing on youth in this particular opioid coalition meeting, but do we have are we putting social media and those those platforms, information around, the increase in, educating around the dangers of fentanyl, anything that's impacting our young people? Are we able to do that?
Yes, so we do have all the social media channels covered, and we actually have a campaign that's ongoing on TikTok in particular that it's a 15-second ad that we've been just buying ad space for about fentanyl. And it goes directly to the Opioid Coalition page that lists all the different resources and medication-assisted treatment that's available. So it's interesting because one of the reasons why we're focusing on youth in this particular program is that the vast majority of clicks we've had have been from 14 to 17-year-olds locally here in Sacramento. There were just in a month span, there was over 150 clicks in that age range that clicked on the ad and went to our website. So it's definitely gaining some traction with education. So I do encourage everyone that's on the call today, if you have resources or things that you would like for us to push out into the community via social media, you can either email me or actually preferably Lauren. Lauren, if you wouldn't mind throwing your email in the chat, she's our AmeriCorps Vista. She handles all the social media for us. Thanks,
I do
Lauren.
have a suggestion.
Sure.
I am 40, and so I know nothing about the trends on TikTok and things like that. And so we made sure to put in charge of our social media somebody who is of Gen Z, because there are like weird TikTok trends and things like that happen, like certain songs and things like that. So I highly recommend like tapping into like some Gen Zers, if that makes sense, on your
Well,
stuff.
we have, yes.
Good.
At least with our channel, Lauren and Marley, our previous sister, they're Gen Z. So, and I'm definitely not either. So
yeah, there's some I don't understand, but it makes sense to them.
Well,
something to
go ahead, Lauren.
Something to know with the TikTok that Marley's been working on, the number of clicks that she got for 14 to 17-year-olds within 5 months of last year was over 206,000.
That's crazy. Okay. All right. Well, Bob, again, thank you so much for joining us today. I think it was just really beneficial for everyone on the call.